This conference
theory
will now
question
be
also you may
recorded.
get as a essay question or 4 marks question. Okay. So acute flaccid paralysis. What do you mean by that? Anybody? Any examples for acute flaccid paralysis? Because this is a revision class, already finished in previous classes and also in 6th and 7th semester clinical postings, which is important for both for your practical examination and also theory paper. Also you may get acute flaccid paralysis. Acute flaccid paralysis causes or differential diagnosis, or you may get as a acute flaccid paralysis surveillance. Okay. Examples for acute flaccid paralysis.
Poliomyelitis, ma'am.
Polio, ma'am.
Pardon me, I am unable to hear you.
Polio, ma'am.
Be loud and clear, Chandra. Dirisha, who is talking?
Polio, ma'am.
Poliomyelitis. Okay. Poliomyelitis, one of the DD or differential diagnosis for acute flaccid paralysis. What are the other causes? Commonest causes in pediatric case group. One is poliomyelitis.
Myasthenia gravis, ma'am.
Be loud.
Myasthenia gravis, ma'am.
Myasthenia gravis. Okay. Any other causes for acute flaccid paralysis? Flaccid, you have to remember here, flaccid means
Guillain-Barré syndrome.
spasticity. Tone is decreased, floppy child, floppy infant.
Guillain-Barré syndrome.
Guillain-Barré syndrome, good. I think only a few days ago only I took the class on Guillain-Barré syndrome. That time also I told you about this differential diagnosis. What are the differential diagnoses? Be fast. It's very common topic.
Transverse myelitis, ma'am.
Hypokalemia, ma'am.
Myelitis, good. Any other
Traumatic
condition? Traumatic neuritis. Any metabolic causes? Metabolic causes or electrolyte disturbances can present.
Hypokalemia, ma'am.
Hypokalemia or hyperkalemia can cause paralysis. Hypokalemia and hyperkalemic periodic paralysis. Any other condition? Metabolic causes or diseases or metabolic disease. I am talking about inborn errors of metabolism, like that they may present. Intermittently paralysis. Okay, any infective etiology, infective causes? Infections.
Viral myositis.
Be loud.
Rhabdomyolysis.
I'm unable to hear you. Rhabdo? You're telling something.
Rhabdomyolysis, ma'am.
Rhabdomyolysis. Here that causes hypokalemia or hyperkalemia. Due to metabolic cause only it can present, but it's not that much. Most common other conditions are acute intermittent porphyria. Never heard about that? Porphyrias can present with paralysis. Metabolic. Infective. Diphtheritic paralysis. Post-diphtheritic paralysis. Never heard? Diphtheria. Complications of diphtheria. Anything? Lyme disease, botulinum toxin, botulinism, all are other causes for flaccid paralysis. Okay. Acute means it should be acute in onset. So acute flaccid paralysis is defined as onset of paralysis. That acute means should be less than 4 weeks in duration in a child age less than 15 years for which no obvious cause has been found, or paralysis in a person of any age in whom poliomyelitis is suspected. So this is the definition. All of you should remember what is AFP, acute flaccid paralysis. Sometimes in essay question they will divide into definition, these many marks, 2 marks, causes these many marks, 3 or 4 marks, management, like that they divide. So unless you write the definition, though they won't give 2 marks. So all of you have to remember it's a very common condition topic. So acute flaccid paralysis is defined as the onset of paralysis, that means less than 4 weeks in a child age less than 15 years for whom no obvious cause has been found, or a paralysis in a person of any age in whom polio is suspected, is the definition of AFP, acute flaccid paralysis. You may get a long case or essay question or 4 marks question or 2 marks question. So paralysis is associated with loss of muscle tone. That's what it's called, and reflexes also. That's what it's called as flaccid paralysis. And it's a, all of you should remember why this topic is included for MBBS students is all of you should report the all cases of AFP if the age of the child is less than 15 years to a surveillance medical officer whenever you are in India. For that purpose, all of you should know what is AFP, what are the cases comes under acute flaccid paralysis. And all cases, whenever it come to notice, should be evaluated or investigated within 48 hours of diagnosis. So otherwise you may miss the diagnosis, especially in poliomyelitis. When was the last polio case was identified in India or detected? Anyone? Last wild poliomyelitis in India was
2011,
detected in 2011 from West Bengal. This you should remember in orals or in entrance, PG entrance also they will ask. That's a type 1 type wild poliovirus type 1 2011 in West Bengal. So AFP case definition is a sudden onset of weakness and fluffiness in any part of the body in a child of less than 15 years of age or paralysis, as I told you, of any person in whom polio is suspected. And we should exclude, no history of trauma should be there. There should not be any electrolyte imbalance like post-GE. There most commonly hypokalemia, and that can present with fluffiness. So you should exclude electrolyte imbalance and any history of trauma. Then you have to suspect AFP. Why all the flaccid paralysis are included in acute flaccid paralysis surveillance or acute flaccid paralysis definition? Because other cases also can mimic and increase the sensitivity. If you only take polio, you may miss the atypical presentations. For that purpose, all acute flaccid paralysis cases should be included in acute flaccid paralysis surveillance. So if acute flaccid paralysis is there, this type of like tone will be lost, child will be in pit-to-prog position. So what are the causes or etiological diagnosis for acute flaccid paralysis? So depending upon the anatomical site, causes will be like anterior horn cell. Involvement of anterior horn cells are poliomyelitis causes like poliomyelitis, poliovirus, and Japanese bee encephalitis. Dorsal root ganglion involvement, Herpes simplex virus and cytomegalovirus and rabies. These also can present with acute flaccid paralysis. And spinal cord lesions, acute transverse myelitis. Usually at the level of the lesion, transiently it will be lower motor neuron type of paralysis. Below the lesion, it will be upper motor neuron type of paralysis. That's why acute transverse myelitis is included in acute flaccid paralysis. And trauma to the spinal cord also will present like acute flaccid paralysis. Space occupying lesion, same. At the level, it will be lower motor flaccidity will be there, and below the lesion will be the upper motor neuron type of lesions. And parasitic infestations, even tick-borne disease like the Lyme's disease is a tick-borne disease. And peripheral nerves involvement like Guillain-Barré syndrome, chronic inflammatory demyelinating polyneuropathy after post-viral infections, vitamin B12 deficiency, diphtheria, rabies, heavy metals, and hypokalemia. These also can cause acute flaccid paralysis. Neuromuscular junction lesions like myasthenia crisis, organoporous poisoning, botulinum toxin. Muscle involvement, polymyositis. This is also post-viral, and Lyme disease and toxoplasmosis. So these are the causes depending upon the anatomical site. So why it is mainly stressed in less than 15 years? Because poliomyelitis occurs predominantly in children of less than 15 years, and occasional cases can be reported more than 15 years. That's why any age where poliomyelitis is suspected, sometimes they present with pseudo hernias, especially in abdomen. If there is because it's a poliomyelitis, asymmetrical involvement will be there, not uniformly, not all muscles will be involved. Sometimes only one group of muscles in the abdominal wall or back of the abdomen or anterior wall of the abdomen involved. That weakness will lead to prominence in that part. That called as pseudo hernia. This is one of the manifestation of poliomyelitis. So whenever if you come across a case of acute flaccid paralysis, always think first we have to think it's a medical emergency, because sometimes it's very ascending type of paralysis like in GB syndrome can involve the respiratory muscles and leads to respiratory failure. If you won't diagnose and you won't support the respiratory functions, the child may die. So this is a medical emergency always. Then you have to take the key steps in the management as follows. First is respiratory care is very important. To check for the respiratory involvement in the form of rapid breathing, shallow breathing, or paradoxical respiratory efforts, and use of accessory muscles of respiration. So early support and intubation is critical for final outcome, good final outcome. So always remember, don't be hurry in informing. You should inform to the health authorities, but first take care of the child, stabilize the child, then only think about the reporting to the SMO, that is surveillance medical officer. Next, bulbar weakness, especially it's whenever bulbar weakness, they're more prone for respiratory insufficiency. So we have to check for the bulbar weakness, bulbar muscles weakness. Like symptoms and signs suggestive of bulbar weakness are pooling of secretions, ineffective, or weak cough, nasal regurgitation fluids indicates bulbar weakness, bulbar poliomyelitis. Usually, bulbar poliomyelitis also associated with cranial nerve involvement. Next, you have to manage the cardiovascular stability is there. Sometimes they may go, if there is bulbar involvement, they may go for shock, cardiovascular shock also. So under ideal circumstances, ECG electrodes should be attached to the all AFP patients if it is possible. Then check for the cardiac status. And rule out dyselectrolytemia, especially hypokalemia, which is a treatable condition. If you give, usually hypokalemic patient, they will brought in hands, sometimes with the head drop or total weakness. If you detect hypokalemia, if you supplement slowly, usually within 24 hours, child will sit and walk and everything, power will be normal and child will do his or her works normally. So that much dramatic response will occur in case of dyselectrolytemia. So you have to check the electrolytes and correct it immediately. And snake invasion is a must. We have to look for the any snake bite marks are there or any history suggestive of that, because especially crite and these neurotoxic snake bites can present like paralysis. Next, coming to the clinical assessment. Depending upon the clinical assessment, there will be clue to your diagnosis. So once a child is stabilized, then you have to go for the evaluation and to know the cause. So with depending the onset of paralysis, within hours to few days, very acute onset. Think about Guillain-Barré syndrome. That time I told you one scenario also. Usually they will go to some shopping or movie theater, come back. Within few hours, the child, the person will become totally immobile. Severe sudden onset of weakness will be there in case of Guillain-Barré syndrome. That typical history will be there. Within hours, they will lose the tone. And in case of traumatic neuritis, history of trauma will be there, or history of any injections into the gluteal region. Usually there will be traumatic neuritis, and asymmetrically only one limb or one part of the body will be involved in traumatic neuritis. And transverse myelitis also within hours to few days. And myasthenia crisis, myasthenic patient, they will go into crisis, then they will present with this floppy weakness. And viral myositis, post-viral infections are along with the viral infection, there is a myositis. So severe muscle pains with they can't move also. Sometimes pseudoparalysis will be there, like in case of osteomyelitis or arthritis, severe arthritis, septic arthritis, that part of the limb child will not move. But you have to examine carefully. It's due to the tenderness, pain of that joint involvement. In case of arthritis or osteomyelitis, they are unable to move the limb. So that is called as pseudoparalysis. Or in case of scurvy also, due to bone pains, they can't move the limb. And within 2 to 3 weeks, history is there. Then poliomyelitis, Japanese bee encephalitis, tick bite paralysis, that is Lyme's disease. Weeks to month, Lyme disease, post-D3 paralysis, and months to years, most probably rabies, we have to think. Coming to the progression of paralysis, maximum deficit at onset, very dense, severe involvement, traumatic neuropathy will be the cause. Hours to few days progression, poliomyelitis, JE. And 2 to 4 weeks, again we had still it's there, paralysis, Guillain-Barré syndrome, varicella zoster paralysis, tick bite paralysis. And few weeks to months, Lyme's disease and polymyositis. Next, asymmetric in involvement, if we have to two limbs are equally involved, both lower limbs are involved, symmetrically up to knee only or up to hip joint weakness is there, then it's most probably GB syndrome. Symmetrical involvement always GB syndrome. Transverse myelitis, there will be a level in case of transverse myelitis, rabies paralysis and botulinism. These cases involvement will be symmetrical, both sides will be at same level, weakness up to same level will be there, but it is asymmetrical. One limb up to and asymmetry also 3/5 in one limb, 2/5 or maybe 4/5 power in one limb, like that asymmetry will be observed in case of poliomyelitis and JE, encephalitis and traumatic neuropathy. Traumatic neuropathy only one limb will be involved, other limb will be normal. So the symmetric involvement, poliomyelitis and traumatic neuropathy common, followed with JE. And symmetric involvement, GB syndrome and transverse myelitis are common. Other causes are rabies and botulinum. So depending upon the onset, depending upon the progression of paralysis, depending upon the symmetry or asymmetry, sometimes even with sensory features. Sensory features are more common with neuropathy secondary to neurotropic viruses like rabies and varicella zoster. And also ZB syndrome variable. Sometimes they will tell about paresthesias, Glowen-Stark paresthesias, especially typical in case of GB syndrome, and transverse myelitis, Lyme's disease and traumatic neuropathy. Sensory features are more common. Sensory features are very, very rare. It won't be there in case of poliomyelitis. And deep tendon reflexes, areflexy is a commonest feature in case of GB syndrome, and spinal shock in cord lesions, spinal shock condition in cord lesions. Bladder and bowel involvement always present in transverse myelitis, but it won't be there in poliomyelitis. In case of traumatic neuritis also, bowel and bladder involvement won't be there, but in GB syndrome sometimes will be there, but it's a transient only. So it is there always in case of transverse myelitis. Fever at onset of paralysis, poliomyelitis and non-polio enteroviruses associated paralysis, it will be there. But GB syndrome and all those cases, only prior history will be there. 1 week or 10 days back, child had fever or gastroenteritis, like that history will be there. And in case of viral myositis, fever may be there. So these are the clues. So what investigations usually, other than sending the stool for AFP surveillance, we have to send the immediately serum potassium levels. As I told you, if it is hypokalemia or hyperkalemia, can correct. And MRS pain, it's last to be done, not first. Depending upon the nerve conduction studies and nerve stimulation test and electromyography, we can conclude or exclude GB syndrome and other conditions. And if you suspect poliomyelitis, CSF examination can be done immediately if the child is stable. Usually it shows pleocytosis, especially lymphocytosis, because it's a viral infection. But protein levels will not be that much raised. But in case of GB syndrome, after 1 week or 10 days after the onset of weakness only, you have to go for the CSF analysis. Before 1 week, CSF findings won't be that much typical. So after 1 week or 10 days of onset of weakness, in case of GB syndrome, if you send CSF examination, usually there will be albuminocytological dissociation. What is that meaning? What is meant by albuminocytological dissociation? Roll number 25. Roll number 25, 26, 27.
26 present.
So what is albuminocytological dissociation? That is a typical feature of Guillain-Barré syndrome, GB syndrome. Never heard albuminocytological dissociation?
CSF
Anybody?
proteins increase.
Be loud and clear. Others also should listen to you. What is albuminocytological dissociation? General medicine also will get the same question.
CSF proteins increases, ma'am.
So cell count will be normal and CSF protein will be raised. That's why it called as albuminocytological dissociation. Actually, both should be usually in case of pyogenic meningitis, cell count will be also increased and proteins also will be increased. But here what happens, cell count will be normal or slightly raised, not that much significant, but protein levels will be very high. That's why it's called as albuminocytological dissociation. There are 2 or 3 conditions are there. That is also PG entrance bit. Search and note what are the conditions where you can observe albuminocytological dissociation. One is ZB syndrome. and serum creatinine phosphokinase to know the muscle myositis and other muscle conditions. Urine for parvobilinosis in case of porphyrias, and Lyme's disease serology if you suspect Lyme's disease. So finally, MRI is fine. Especially it is useful in case of transverse myelitis. Not in other conditions, especially we won't go for poliomyelitis or GB syndrome. Only nerve conduction studies and EMG will be useful. So depending upon the case, examination and history, you will go for the investigations. Not all investigations in all children, only depending upon the case only. But differential diagnosis only, we have to go for some investigations. Next, coming to the AFP surveillance. So once you suspect and you will exclude the other conditions, we have to immediately inform to the AFP surveillance medical officer. So it's nationwide AFP surveillance is the gold standard for detecting the cases of poliomyelitis, because you may be thinking already India declared as polio free. In which year? In which year India declared as polio free?
2014.
2014, good. Because after 3 years, consecutive 3 years, there are no cases from the last case, then that country will be declared as polio free. But still we are continuing AFP surveillance. Why? What is the reason? Why India is
Vaccine
continuing?
derived polio virus.
Okay, one is vaccine derived poliomyelitis cases may be there. Anything else? Vaccine derived poliomyelitis can be excluded if you switch over to killed vaccine, injectable polio vaccine instead of oral polio vaccine. If you go
Sometimes
for
there may be mutation.
for injectable polio vaccine or inactivated polio virus vaccine, that is killed vaccine, there won't be any vaccine derived poliomyelitis, but still we are continuing. Why? Because our neighbor countries, Pakistan and Afghanistan, is still having polio cases, active polio cases. Still, even in according to 2020 September 30th, also these two countries are contributing around 200 cases from Afghanistan and Pakistan combinedly. So that's why we should be very cautious, because borders only, neighbor countries only. So anytime you can import cases from that place. So surveillance identify new cases and detects importation of wild poliovirus from the neighbor countries. So 4 steps of surveillance are finding and reporting children with AFP, transporting stool samples for analysis, isolating and identifying the poliovirus in the laboratory, mapping the virus to determine the origin of the strain, which strain it is, where it is detected, all those things. Depending upon that, we can take proper precautions. AFP reporting should be sensitive, at least that called as AFP index, acute flaccid paralysis surveillance index. AFP index means at least 1 case per 1 lakh population of children less than 15 years. If it is there more than 1 case per 1 lakh population of less than 15 years, AFP case is not equivalent to poliomyelitis. Non-polio cases like transverse myelitis or traumatic neuritis or GB syndrome or even Bell's palsy or other causes of weakness may be there. So that indicates sensitive that people are doing good surveillance. Why this? Because this background rate of AFP from other parts of the world also. So each district at least 2 cases per 1 lakh population of children is less than 15 years. Then it's a sensitive reporting. People are reporting correctly. So surveillance procedure, how whenever you detect a acute flaccid paralysis case, there is polio or non-polio, reporting to the medical officer is a must. Then medical officer will report to the district immunization officer. Then from district immunization officer to state EPA officer and national polio surveillance unit. So this is the system of AFP report. So there are 2 types, active surveillance and passive surveillance. Active surveillance means when district immunization officer or surveillance medical officer will comes and takes the data regarding the hospitals health work from the health workers and Anganwadi workers and TVA regarding the acute flaccid paralysis weakness. That is called as active surveillance. Passive surveillance means reporting unit will send routinely weekly reporting to the medical officer who is in charge of surveillance. That is the surveillance medical officer. That is called as passive surveillance. So ideal for the surveillance, acute flaccid paralysis surveillance is the collection of stool specimen. So when to collect? As soon as possible. Whenever you suspect acute flaccid paralysis in any child of less than 15 years, we have to collect the stool specimen. Ideally, as early as possible, at least within 14 days of onset of paralysis, 2 specimens at least 24 hours apart. This usually asked in the oral, so you should know with ideally as early as possible or within 14 days of onset of paralysis, 2 specimens with the gap of 24 hours, because to cover the intermittent shedding viruses, and to be collected before outbreak response immunization. That means outbreak response immunization means whenever AFP case is there, surrounding 500 children will be given oral polio vaccine. So why for 14 days means viral shutdown in the stools will be maximum the 14 days, but it will be there, but lower amounts up to 42 to 60 days also, but it's not that much effective. So how to collect? Usually it should be collected in a dry, clean, wide mouth, leak-proof, preferably transparent container, at least 30 to 60 ml size, with screw and cap which tightens securely, because the virus will be there, so it will be tightened securely. If there is absence of such container, any clean dry container may be used, but prevention of leakage is very important. Container need not be sterile, but it should be leak-proof. Do not collect a specimen if the onset is of the paralysis is more than 2 months. That type of cases has to be followed for residual paralysis. If the residual paralysis is there, most likely it will be a case of paralytic poliomyelitis. This is the photographs of the containers to collect the stool specimen. And container should be waterproof and should be labeled with waterproof label with name of the patient, that EPA, that's epidemiology program ID number, identity number, and specimen number written in a indelible ink. It should be written with the patient name, EPA ID number, specimen number, all those. And the amount to be collected is 5 to 8 grams or adult thumb size. This is also commonly asked by the examiners, how much stool has to be collected. 8 grams or adult thumb size sample has to be collected, and should be transported with proper care. Reverse cold chain, we call it reverse cold chain. Specimen container should be packed in a plastic seal bag, and possibly both specimen from one case to be packed in a single carrier. Temperature less than 8, we have to maintain less than 8 degrees Celsius. And vaccine carrier with 4 fully frozen ice packs should be there. If stool has to be delayed for transport means it should be kept in a deep freezer. Provision of replacement of ice in case of delay in the and carrier shipmates all should be there. So that's what called as reverse cold chain should be maintained to transport the stool sample from the patient to the laboratory. So virological classification AFP cases. AFP case is there, then wild poliovirus, it's confirmed. No wild poliovirus detected in the stools, 2 adequate samples, then we can discard it. But inadequate samples, then we have to follow up for 60 days. No residual weakness, we can discard as non-polio. Residual weakness is there, then expert review we have to compatible. Or the patient died, then we have to, after expert opinion, it may be compatible or discarded. Case can be discarded. So adequate stool specimens, wild poliovirus, confirmed case, no wild polio, discarded as non-polio virus. 60 days follow-up is very, very must. All cases with inadequate stool specimens has to be followed up. All cases with vaccine poliovirus isolated, even if stool specimens were adequate also, it follow up for the 60 days. 60 days follow-up means 60 completed days should be. Look for the residual weakness. Thorough CNS examination has to be done. Cross-check all data and case form and notify changes to the National Polio Surveillance Unit. So like that, complete CNS examination has to be done. What is the power? What is the tone? All muscle groups has to be examined, because as I told you, it's, in case of polio, it's a asymmetrical weakness, or only small group of the muscle may be involved. Sometimes the phantom hernia or pseudo hernia like presentation also will be there in case of abdominal wall weakness. So after follow-up of 60 days, even minimal limping or wasting, asymmetrical skin folds, that means retinal weakness only. Have to notify that. So what is outbreak response or outbreak control procedure? Collect stool sample, that is ORA, that's outbreak response immunization should be done in rural area. Entire village has to be immunized with OPV if the child less than 5 years of age children. In case of urban areas, 500 children below 5 years should be immunized with OPV. So what are the good AFP program indicators, sensitivity indicators? So at least one case or more than one case per 1 lakh population less than 15 years. That is a good AFP surveillance. And weekly negative reporting, monthly negative reporting, percentage of 2 stool samples collected within 2 weeks of onset of paralysis should be more than 80%. Then only program surveillance is a good. How long to continue surveillance means 3 years after the last confirmed case. This required for the certification, we got it, but still we are continuing the AFP surveillance because in view of neighboring countries having active polio cases, wild polio cases. So records of case should include date of paralysis onset, period of progression, presence of fever at onset, residual paralysis at 60 days, atrophy at 60 days, location of paralysis, final diagnosis. All these should be there in the record of a patient suspected of acute flaccid paralysis. So these are the data from the WHO charts. This up to 2017, 2009 to 2017, various vaccine-derived poliomyelitis in India. And this is the old one. So we are at polio eradication and end plan. These are not needed for you. So these are the milestones. 3 distinct steps of polio endgame strategy are: before end of 2015, introduce at least 1 dose of IPV in routine immunization that is already taking place, and switch over from the trivalent OPV to bivalent OPV. That is 3, instead of 3 serotypes, only we are using 2 serotypes containing OPV, oral polio vaccine. Which serotype was excluded from this OPV? Anybody? Bivalent contains serotypes 1 and
2, ma'am. 2 is excluded.
2
1
is
and 3 included.
2 excluded, so 1 and 3 only. This happened in 2016. Now gradually we will withdraw the oral polio, even this bivalent, and only we will go for IPV, not OPV. Withdrawal of bivalent OPV and routine OPV use, then we will switch over to IPV. That's a polio endgame strategy. Every year, October 24th was World Polio Day. So this year's theme is 1 day, 1 focus, ending polio. So every child of less than 5 years should be vaccinated with OPV or IPV compulsory. World Polio Day is 24th October. So first link in the surveillance chain are staff in health facilities. So from district health center, PHCs to large hospitals, even our hospital, Aster Medical College also report cases every weekly. Whether cases are there or nil, report to acute flaccid paralysis surveillance medical officer. So if polio virus is isolated, the next step is to distinguish between the wild or vaccine related. So most of the vaccine related poliomyelitis cases used to come from serotype 2, and the last case of wild polio type 2 was detected in 1999. That's why this serotype 2 was eliminated from the oral polio virus vaccine. So this is not good, but these are the surveillance indicators. What are the, how sensitive? Completeness of reporting. At least 80% of expected routine AFP surveillance report should be received on time. That means before report should be paralysis should be reported before 14 weeks of onset of weakness. Sensitivity surveillance, as I told you, one or more than one cases for 1 lakh children of less than 15 years, especially in endemic regions, that indicates sensitivity surveillance. Completeness of case investigations, all reports should come, at least 80% of the cases report should come in time. And completeness of follow-up, at least more than 80% of AFP cases should be followed up for more than 60 days after the onset of paralysis. That is completeness of follow-up. Laboratory performance, all AFP case specimens must be processed in a WHO accredited laboratory within the global polio laboratory network. Then these are the indicators of good surveillance. So these are the reports from this is recent one. We can report from Andhra Pradesh number of AFP cases from 2017 to 2020 up to September 30th. This is a recent most slide. Here you can observe AFP cases, not poliomyelitis. AFP means like Guillain-Barré syndrome or transverse myelitis or traumatic neuritis or some other like even Bell's palsy. Also we have to report. Any other weaknesses which are included AFP has to be included. In 2017 is around 347 like that, and 2018 412, and 2019 it was 400 around 400, and 2020 up to September it's 163 like that. These are the AFP cases reported from Andhra Pradesh from 2017 to 2020. So what are the laboratories are there which are recognized by the Ministry of Health? These are the laboratories to where we have to send the stool sample. Usually we will inform to the medical officer concerned and our district immunization officer and surveillance medical officer. They will come and give the guidance. So Sanjay Gandhi Postgraduate Institute of Lucknow and National Institute of Communicable Diseases New Delhi, and in even National Institute of Virology Lab in Bangalore. These are the some of the nationally accredited laboratories for polio virus detection of polio viruses. Pasteur Institute of India, Kunur. These are the laboratories accredited with the Ministry of Health. So who are those people? Albert Sabin. He's a scientist who discovered, who actually invented. Albert Sabin for famous for
Polio. Oral polio.
Oral polio vaccine. So that's what it's called as Sabin vaccine. OPV otherwise called as Sabin vaccine. Jonas Salk, IPV otherwise called as
Inactivated.
Salk vaccine. Killed vaccine, that is injectable polio virus vaccine or killed vaccine is the Salk vaccine. That's why named after him, Salk vaccine. Who is Landry? Jean-Baptiste Landry. Landry for Pavan. Pavan, helpayava unnava class lo. Are you there?
Ma'am, yes, ma'am.
Landry. Jean-Baptiste Landry for. Never heard about Landry's paralysis. What is Landry's paralysis? Ascending paralysis. It's a symmetrical ascending paralysis, Landry's paralysis. What is that? Scientist of the day, avatled the cap ledu. There is no cap, no scientist of the day like that. You've forgotten everything about the scientist, medical scientist. Anybody? What is Landry's paralysis? Ascending paralysis, symmetrical ascending paralysis. In which condition you will find? Asymmetrical paralysis, ascending asymmetrical paralysis is poliomyelitis. Guillain-Barré syndrome. Other name is Landry's paralysis. Landry's ascending paralysis. So Landry and George Guillain and Jean Barry, all three scientists are involved in the identification and clinical features and labeling of the GB syndrome or Landry's Guillain-Barré syndrome. And Charles Miller-Fisher variant of GB syndrome. So these are the scientists involved in acute flaccid paralysis. That's why I kept these scientist photographs. Any doubts regarding acute flaccid paralysis? So you should know the definition of acute flaccid paralysis. Acute means less than 14 weeks. Less than 14 weeks duration should be there. And flaccid means it should be flaccid paralysis. Hypotonia, weakness of one or more than any other parts of the body may be involved. So that's why called as acute flaccid paralysis, and the age should be less than 15 years or any age where poliomyelitis can be diagnosed. That is acute flaccid paralysis definition. You should know the definition, all of you. And what are the causes for acute flaccid paralysis? Are the most common differential diagnoses are transverse myelitis, GB syndrome, traumatic neuritis, and poliomyelitis. These four you can differentiate with so many categories. It is there is a tabular form in our OPG 8th edition or 9th edition. You can read depending upon the fever at the time of onset, depending upon the sensory involvement, depending upon the cranial nerve involvement, depending upon bladder and bowel involvement, and whether it's a symmetrical paralysis or asymmetrical paralysis. With those findings, we can categorize clinically, differentiate between. In case of symmetrical weakness, always think about poliomyelitis. If it is symmetrical, always think about Guillain-Barré syndrome and transverse myelitis. So symmetrical involvement, always think of, and usually in case of GB syndrome, it's an ascending type of paralysis. Usually initially they will have lower limb weakness, then truncal weakness, then involves the chest muscles, and then upper limbs, like that. It's ascending and symmetrical GB syndrome. Symmetrical type, one more condition is transverse myelitis. Usually transverse myelitis at the level of the lesion, usually it will be lower motor neuron type of lesion, but below the lesion will be upper motor neuron type of features will be there. Like, I think you know what are the upper motor neuron signs and what are the lower motor neuron signs. Who is roll number 15? Absent. Roll number 15.
Yes, ma'am.
14. 15. Who is roll number 15?
Sweta, ma'am.
Sweta, can you tell some features of upper motor neuron lesions? Try.
Babinski sign positive, ma'am.
Okay, that means plantar extensor will be there.
Exaggerated tendon reflexes.
Exaggerated deep tendon reflexes will be there.
Spastic paralysis.
Tone will be increased. Spastic paralysis. Increased tone you have to mention. Not always spasticity. Even rigidity is upper motor or lower motor. Rigidity. Spasticity and rigidity, you are telling only spastic
Upper motor neuron. Upper motor. Lower motor. Flaccid,
and rigidity. Lower motor will be flaccidity.
Flaccid.
So
Flaccid.
rigidity, where do you find?
Upper motor.
Parkinsonism. Ma'am, Parkinsonism, ma'am.
Extrapyramidal lesions. Rigidity will be there in extrapyramidal lesions. Pyramidal, it's spasticity. Both pyramidal and extrapyramidal are upper motor neuron lesions. Anything else? That's all. Okay. Tone will be increased. Deep tendon will reflexes will be exaggerated. Superficial reflexes. What happens to superficial reflexes in upper motor neuron lesions? Sweta.
Yes, ma'am.
What happens to superficial reflexes in upper motor neuron lesions?
Exaggerated, ma'am.
Superficial reflexes like abdominal reflex in case of hemiplegia, what happens? Absent.
Superficial reflexes are lost.
Okay.
Absent.
Okay. Absent superficial reflexes. So these are the features of upper motor. Lower motor neuron lesions signs. Roll number 14. Name some.
Yes, ma'am.
List out the features of lower.
Ma'am, in that poliomyelitis, ma'am.
So conditions are poliomyelitis, and what are the conditions? Lower motor neuron lesions, poliomyelitis.
Yes, ma'am. And ma'am, in that clonus will be absent, paralysis will be flaccid, reflexes, superficial and deep, both will be lost.
Okay. What happens to plantar reflex?
And tone will also be lost.
Tone will be lost. That's why called as flaccidity. Okay.
Yes, ma'am.
Plantar reflex will be plantar. Babinski sign will be positive. Lower motor neuron lesions.
Yes,
what happens to plantar reflex?
Negative, ma'am. Negative.
What do you mean by negative?
Negative plantar.
There is no
Absent.
negative.
It will be absent.
No, what do you call?
It
Plantar?
will
Plantar flexor.
flexion.
Plantar
Yes,
flexion.
ma'am.
So that you should remember, because sometimes they will ask what are the features of lower motor, and atrophy will be there in lower motor or upper motor type of lesions. Atrophy of the muscles. Chahat. Atrophy of the
Ma'am,
muscles, wasting
lower
of the
motor.
muscles. Huh? Wasting
Lower
of the muscles
motor,
will be
ma'am.
lower motor lesions. Any other special other features will be there in lower motor lesions? Twitchings, muscle twitchings also will be fasciculations.
Yes,
Fasciculations will
ma'am.
be present in
Fasciculations, ma'am. Lower
lower
motor
motor
neuron.
lesions. So all of you should remember, because these are the commonly asked questions whenever you come across a case of GB syndrome or hemiplegia or paraplegia cases in general medicine or pediatrics. They will ask what are the signs of lower motor neuron lesions, what are the signs of upper motor neuron lesions. Usually what are the upper motor means cortex and cranial nerve nuclei and above anterior horn cells all comes under upper motor neurons. So lower motor is below cranial nerves, below the cranial nerve nuclei, and anterior horn cells and below that anterior horn cells and spinal roots and neuromuscular junctions and muscle, peripheral nerves all comes under lower motor neurons. So you should know what are the signs of lower motor neuron lesions, what are the signs of upper motor neuron lesions. So accordingly you can differentiate. That's why in transverse myelitis, at the level of the lesion will be transverse myelitis means at the usually spinal cord lesions. So at the level of the lesion, usually lower motor neuron signs will be there. Below the lesion will be upper motor neuron signs will be there. And sensory level, clear cut sensory level will be there in case of transverse myelitis. And in case of poliomyelitis, there won't be any sensory involvement. But in case of GB syndrome, sometimes they may tell sensory features like paresthesias, especially glow and stalk paresthesias will be there in case of GB syndrome. Traumatic neuritis also, that involvement of the single nerve, usually they may tell sensory features. But involvement of bladder and bowel involvement is always there in case of transverse myelitis, but it won't be there at all in case of traumatic neuritis. But in GB syndrome may be there or may not be, but it will be transient only if it is there also. And poliomyelitis, it won't be there, involvement of bowel and bladder. Like that we can differentiate depending upon the symmetry. Asymmetrical in case of poliomyelitis and traumatic neuritis. Symmetry in case of transverse. So we can put a tabular form also. The features, what happens to deep tendon reflexes, what happens to sensory involvement, autonomic disturbances also. Autonomic disturbances usually may not be there in case of poliomyelitis, but in case some variants of GB syndrome, autonomic disturbances may be there. Then only bowel and bladder involvement will be there. But transverse myelitis will be there. But traumatic neuritis, there won't be any autonomic disturbances. Like that, we have to differentiate clinically. Then only accordingly we will go for the further investigations. And proper history and examination, you should exclude the poisons also, like organophosphorus poisoning, lead poisoning, and also snake invasion. Any snake bite history or examination, any fang marks are there also, you have to examine to rule out other conditions whenever a child with acute flaccid paralysis comes to you. And report all cases of acute flaccid paralysis to the surveillance medical officer. And send 2 stool samples, ideally taken 8 grams or adult thumb size in a leak-proof container, and within 2 samples with 24 hours apart, and ideally before the 14 days after the onset of paralysis. And you have to send it in a cold chain, reverse cold chain, maintaining temperature less than 8 degrees Celsius. So this is the about acute flaccid paralysis definition, causes, differential diagnosis, how to diagnose and how to report a case of acute flaccid paralysis, what is follow-up up to 60 days after the acute flaccid paralysis, what is the status of AFP in India and Andhra Pradesh at present. And as on today, we are not having any wild polio viruses. Only occasionally we are getting vaccine-derived polio viruses only. That's why you are gradually eliminating vaccine-derived poliomyelitis is coming due to it's mainly due to the VAP is due to oral polio vaccine only. That's why trivalent we came to bivalent. Gradually we switch over to complete IPV dose only. Now we are giving fractionated IPV vaccine. Fractionated means we are giving 0.1 ml intradermally at 6 weeks and again at 14 weeks along with OPV in a national immunization schedule. In IAP schedule, we will give OPV at birth and 6 months only. At 6, 10, 14 weeks, we will give IPV 0.5 ml intramuscularly. And OPV first booster at 1.5 years and second booster at 5 years. That's all. So any doubts? Any doubts regarding AFP or anything regarding poliomyelitis or polio vaccine, you can ask me. There is time is there at least 5 minutes. Anybody is having any doubts? Divya is not there. Sweta, is it clear? Sweta, are you having any doubts?
No, ma'am.
Ma'am, we want the NIP and IAP schedule, immunization schedule, ma'am, once, and latest one.
Complete schedule, only polio vaccine schedule.
Complete schedule, ma'am. If you can share in the group.
Okay, I think in the coming classes will be taken for the orals. Vaccination class will be there. In that, I will myself or anybody will take on that vaccination topic. That time, national immunization schedule. National immunization schedule. Recent one is 2017 only. You can read from your OPK 9th edition, and I will take class if possible. But meanwhile, you can read from OPK 9th edition. 2017 schedule is the recent schedule for the national immunization schedule, where even pneumococcal vaccine, human papilloma virus, HPV vaccine also introduced in some of the states. Okay. If there are no doubts, I will close the meeting. End the meeting. Pavan.
Yes, ma'am.
Shall I end the meeting or any doubts are there for anybody?
No, ma'am.
Okay then. Bye. Thank you, everybody.
Thank you, ma'am.
Thank you.